Hello everybody, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist. Welcome to OT Conversations. And this is just going to be a very quick conversation and discussion, and it's a basic one. This time I'd like us to talk about the midbrain, which is also known as the mesencephalon. Midbrain is a part of the brain, and it's a part of the brain stem, and this is located between the pons and the diencephalon. So the pons is below it, and then above it is the diencephalon, and this will play a major part in movement, visual and auditory processing, arousal reflexes. Okay, this is what it does. In regard to anatomy of the midbrain, it is divided into three parts. There are three sections. The roof of it is called the tectum. Just think like you're making some, like the roof. And this tectum is located at the back posteriorly, and this tectum will have the superior colliculi, which is responsible for the visual reflex centers, and it helps reorient the eyes and the head toward the visual stimuli. And then you also have the inferior colliculi, and this is now for the auditory reflex centers, which will relay the sound signals to the thalamus. The second part would be the tegmentum, and this one lies now between the tectum and the cerebral peduncles. And what this contains is, it contains the red nucleus, and this red nucleus is involved in coordination, and particularly the coordination of the upper limbs. This contains the reticular formation, and it is involved in arousal, wakefulness, consciousness. It is also containing the periaqueductal gray, or the PAG. And this periaqueductal gray surrounds the cerebral aqueduct, and this modulates pain and it just modulates the pain. Okay, so that's part two. The first part, just to remember: tectum, which is the roof and its posterior; tegmentum, which is now between the cerebral peduncles; and then the next thing would be the cerebral peduncles, or the crus cerebri. And this one is the most anterior part of this. It contains the major motor pathways, three motor pathways. And these pathways are the corticospinal tract. It contains the corticobulbar tract. It contains the corticopontine tract. And these tracts are carrying motor signals from the cerebral cortex, from the main brain, to the brainstem, to the spinal cord. So in terms of the pathway, you can always remember corticospinal, so cortex to spine; cortical bulbar tract, cortex to the bulbar region; and then corticopontine, cortex to the pons. Okay, now in terms of the cranial nerves that comes out, because this is part of the brainstem, so there are some nerves that are coming out, particularly the cranial nerve 3, oculomotor nerve. And oculomotor nerve controls all of the eye movements apart from the movement on the side and down and out. Okay, so cranial nerve 3. It also contains the nerve cranial nerve 4, which is the trochlear nerve, and this controls the movement of the eye into down and out. The functions of this brain this part of the brain, it has a responsibility for movement, motor control, motor movement, because it transmits the motor information from the brain down to the brainstem, down to the spinal cord. So it is corticospinal. So motor movement. It will have a responsibility on the eye movement, which coordinates the visual tracking. It will also have the responsibility for the auditory processing, which helps localization of the sound. So if you do this and the person starts looking at places and localizations, you are stimulating the midbrain. It will have a responsibility with pain modulation, particularly with this periaqueductal gray. It influences the body's response to pain, and it will have a responsibility to a patient's level of arousal and consciousness, because it is part of the reticular activating system, which, like I said, it affects the wakefulness of the person. Now, relevance, clinical relevance. It's very difficult or very seldom that there's going to be a problem directly to the midbrain, but a damage directly to this can lead to some syndromes. For example, the Weber syndrome, for example. This is a stroke that affects the cerebral peduncles and the oculomotor nerve, and it causes the weakness on the one side of the body, and there's going to be a problem with eye movement. You have Perinaud syndrome, and here there is a compression of the tectal region from a pineal tumor, and it leads to problems with vertical gaze, pupillary reaction, and some convergence of the eye as well. So Perinaud syndrome, and there you go. In some levels, in Parkinson's disease, there's degeneration of the substantia nigra, and it's a dopamine producing area of the midbrain, and it leads to some symptoms like tremor, rigidity, and bradykinesia. Okay, there you go, guys. Very simple, very straightforward. I need you to just listen to this over and over and over. Start visualizing it, what's happening. It's just interesting. So it's basic foundational skills for occupational therapists that every clinician should know. Or you need to revisit every now and again. Don't forget about this, especially if you're working in neurology. Okay, there you go. Thank you. If you like it, talk to your friends about it. Learn together, grow together, share it over a cup of tea. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.